In this presentation, we'll discuss food-related issues. Your objectives today are to be able to describe the nutritional therapy rationales for different modified diets. You'll be able to explain the appropriate interventions to resolve food issues like allergies or poisoning incidences. You'll be able to list the risks and the benefits of integrative medicine, traditional, complementary, and alternative medicine. You'll be able to distinguish between alternative medical therapies and integrative medical therapies. You should be able to summarize the potential interactions of herbal dietary supplements with the bioavailability of foods, nutrients, and drugs. And lastly, you'll be able to compare and contrast the different feeding modalities, specifically the differences and the similarities between enteral nutrition and parenteral nutrition. The United States has provided dietary guidelines for Americans, or DGAs, which are updated every 5 years, and the last one was published in 2020. There are 5 key messages that are listed here on the slide, following healthy eating patterns, focusing on a variety of nutrient-dense foods in the proper amounts, limiting added sugar, saturated fats, and reducing sodium, overall choosing healthier food and beverage options, and supporting healthy eating patterns for all, and realizing that every individual plays a role in this. And the goal of this is really to attain and maintain optimal nutritional status for all citizens. And in addition to the United States, most country governments have produced some type of dietary guidelines for their own citizens. Also, I want to introduce the idea of dietary modification, which needs to be addressed, especially in nursing. Sometimes dietary modifications are required to allow the body to heal, to adjust to physical changes, or to prepare for some type of diagnostic test or surgical procedure. Think about the types of dietary modification therapies that you have seen in practice. You might have worked with a patient that has had some type of texture change, like a liquefied or purified diet. Someone that has had some nutrient changes and modifications. A patient with hypertension, perhaps, being on a low sodium diet. Or a person with diabetes who is trying to control their blood sugars, may be on a reduced carbohydrate diet. What about a patient that will not be able to eat for a week or longer? This is a time when maybe tube feeding, or we also refer to it as enteral feeding, may be an option. Or even parenteral feeding. Sometimes we refer to this as intravenous feeding. Additionally, in extreme cases, maybe someone has short bowel syndrome, that patient may never be able to eat orally again. So we need to think about the dietary modifications that will support that patient. This presentation will talk about typical hospital diets, enteral formulas, and parenteral nutrition. The nursing staff will work with a team of individuals that are trained and educated regarding nutrition and patient diets. And generally, the physicians will order what diet is appropriate for the patient and will make adjustments and modifications. CMS, or the Centers for Medicare and Medicaid Services, in 2014 announced a rule change that would allow privileged registered dietitians to also independently order patient diets without requiring supervision from a physician or another healthcare practitioner. And to order lab tests as well to monitor the effectiveness of the dietary plans and orders. And this rule only applies to registered dietitians who are granted these privileges by the hospital system. So it is still within the right of the hospital system to allow or to provide this privilege of making changes to the patient's diet. Now, the implementation of the CMS rule expedites the correction of diet orders that are not effective for the patient, because perhaps a registered dietitian will not have to wait now for a change written by the physician. So really, we are trying to improve and increase the satisfaction of our patient care. There are two basic hospital diets. There is the regular or general diet, and this serves as the basis for any modified diet. And then you might have seen an order that says diet is tolerated, and this allows for a progression of the diet based on the patient's tolerance. And many times you will see this now after a procedure. Clear liquid diets are usually ordered to prep a patient for surgery. But more recently, it was thought that it was more specific and it's really needed for GI types of surgeries or possibly a colonoscopy. Clear liquid diets consist of foods that are clear and liquid at room or body temperature typically. But also included in this is popsicles, also plain gelatin, ice chips, apple or grape juices. And this type of diet helps to prevent dehydration and to keep choline residual to a minimum. However, clear liquid diets are inadequate in protein, fat, fiber, and energy. Evidence-based guidelines recommend a low residual diet before and after colonoscopy to improve the tolerability by patients with no adverse effects. So you're seeing that there's a shift now in the thought, and it's based on the research. The use of clear liquid diets longer than 24 hours can lead to compromised nutritional status and possible nutrient deficiencies. So therefore, hospital facilities should have a policy that orders for clear liquid diets that are only valid for every 24 hours, much like how we have time-restricted orders for antibiotics. There is a difference between full liquid diets and clear liquid diets. Full liquid diets consist of foods that are liquid at room or body temperature. However, they're used to provide oral nourishment for patients that have difficulty swallowing or chewing, or perhaps you have a patient that was involved in a trauma or a surgical procedure that requires their jaw to be wired for some time. But unlike the clear liquid diet, the full liquid diet offers more variety. We also have access to commercial nutritional supplements and also milk. This can help to supply adequate amounts of energy and nutrients that a clear liquid diet would not be able to provide. Full liquid diets can be nutritionally complete if they're well planned and include between meal snacks. The amount of the diet really is dependent on the patient's nutritional status, health status, and what is recommended by the registered dietitian and healthcare staff. Everything that the patient eats really needs to be recorded and monitored daily so that we can continue to ensure adequate energy and nutrient consumption. Lactose-containing or milk-based foods are allowed on a full liquid diet unless the patient is lactose intolerant, meaning that when they eat milk-based foods, they experience nausea, vomiting, distension, or diarrhea. It is possible to obtain lactose-free milk products for these patients, especially to provide sufficient calcium and to avoid unnecessary avoidance of dairy products as a whole. Raw eggs and unpasteurized milk should not be used in the preparation of any food served to patients with a lactose intolerance. Patients and their families have to be educated about the possible dangers of consuming homemade products where they may not understand what is included in the ingredient profile. Another special concern for these patients who cannot swallow thin liquids. A patient that receives a full liquid diet needs to be carefully assessed for any signs of dysphagia and will have a swallow evaluation. If you have a patient that you are noticing is having difficulty swallowing, or a patient that has failed their swallow evaluation, you might consider dysphagia diets. Think of a patient that has ALS or a stroke or has some type of head and neck cancer. They may be a candidate for dysphagia diets. Can you think of some signs of difficulty swallowing that you might have noticed in patients, or signs to look for? If your patient is drooling, choking, gagging, or taking longer than about 10 seconds to swallow their food, they may be suffering from dysphagia. In 2015, the International Dysphagia Diet Standardization Initiative, or the IDDSI, classified different foods and thickened liquids specifically to ensure safe swallowing in our vulnerable patients, regardless of their age or regardless of the facility. And training regarding the dysphagia diets are essential. Dysphagia diets have multiple levels. You see here the different levels there are 4. The most restrictive is the pureed diet. No coarse textures are allowed, and foods are totally blended without any type of lumps. And for the minced and moist diet, foods are to be moist, softened, and easily chewed. Meats are ground up, they're served with gravy or sauce, or soft salads may be also used. At the next level, foods are soft and they need to be bite-sized. Patients cannot receive any hard, dry, sticky, or crunchy foods. And when possible, patients can return to a diet with easy-to-chew foods. Or lastly, level 4, the regular diet. Liquids can also be ordered separately, and they may be thinned or thickened according to the evaluation by the speech pathologist or speech therapist. Thickeners are usually modified with starch or xanthan gum, and physician orders will state one specific viscosity. In most facilities, bedside thickening by the nursing staff is best to ensure that the liquids are consumed at the proper consistency. We also have soft diets, which are sometimes ordered after surgery or when there needs to be a transition from liquid diets to regular diets. And whole foods that are low in fiber and only lightly seasoned are used in the soft diets. You can also provide food supplements or between meal snacks by offering foods that meet the consistency level to add extra energy. When a patient has difficulty chewing, think about the mechanical aspects of chewing. We can provide mechanically altered diets. Foods can be chopped, ground, mashed, or even pureed, and the consistency of the food that is being ordered really depends on the patient's ability. And so it is a collaborative effort between the nurse, the dietitian, and the patient to work together to evaluate the need for the modification and thinking about the preferences within the diet order. Additionally, if there's problems with swallowing as well, then you will have to work with the speech pathologist or speech therapist so that they can follow up with the patient, providing a swallow evaluation to see if perhaps a different diet needs to be altered. Now, some foods naturally have the consistency. Mashed potatoes, ice cream, they're already smooth and easy to swallow. But other foods, we would actually need to add additional liquids like broth, gravies, or maybe even milk so that we can reach the appropriate consistency that's needed to feed that patient. Anytime you use a liquid to add to a pureed food, it should complement the food. It shouldn't conceal the food's original flavor, and it shouldn't be overly liquefied. You still have to be able to provide food that is attractive enough for the patient to eat it. Additionally, we can also use butter, gravy, sugar, honey to add to the foods to increase the density or the energy density of that food. Our food service departments in the hospitals can also use different tools to make pureed foods look more attractive. Think about cake decorating tools. Molds can also be used to shape the food, and it really is, trying to help the patient to eat a food that doesn't typically come or is not typically prepared in that form, knowing that we are doing our best to help them meet their energy requirements. The exact composition and consistency of a mechanically altered diet really is going to vary according to the patient's need, and it can be modified multiple times with additional changes depending on what else is an issue for the patient. So maybe they also need to have a low sodium diet, low carb diet, or decrease saturated fat content. We can always add this to the mechanical altered diet. It's important to remember that the quality of life of the patient really depends on receiving foods that are going to be tasty, appealing, and served at the appropriate consistency. Soft diets are sometimes ordered mostly after surgery or when we're trying to transition from liquid diets to regular diets, and whole foods that are low in fiber and only lightly seasoned are used with soft diets. We can provide food supplements or between meal snacks as well to add those extra energy calories, and we are trying to help them to transition. The diet often has a nebulous meaning, and it's not appropriate for patients requiring mechanically altered diet. So if it's mechanically altered diet that's been ordered, you can't supplement with a soft food diet. There are other examples: low sodium, carbohydrate controlled, gluten-free, high fiber, vegetarian, and allergy-free modified diets. It's important for nurses to assess whether a patient has a true food allergy, something that's been documented in their chart, versus food preferences or dislikes or intolerances. A food intolerance is a non-allergic reaction, and these food intolerances can be caused by toxins, drugs, or conditions such as lactose and gluten intolerances. Intolerances are often dose responsive, occurring only after a large amount of that particular food product is consumed. Many times patients will say, I'm allergic to milk. But when you think about in context of what is going on with them and what they're using it for, you might find that it's really an intolerance. Also, think about patients that are lactose intolerant. They can still have milk, but perhaps they're using Lactaid instead. Maybe patients that are lactose intolerant cannot have cow's milk, but cheeses and yogurts are tolerable. When this occurs, we need to ask the registered dietitian to evaluate the patient further and find ways to include calcium for those patients that are lactose intolerant. And you can see on this figure below the different types of common food allergies and what may not be consumed by all individuals. So some patients that you're working with may require an egg-free diet, shellfish-free diet, nut-free diet. These are examples. Food safety is also important, and the top causes of food poisoning are coming from the different types of viruses and bacteria below. We see norovirus, salmonella, clostridium. We see even Staphylococcus aureus. And the U.S. Food and Drug Administration, the FDA, and also along with the Food Safety Modernization Act, the FSMA, they aim to ensure that the U.S. food supply is safe. They shift the focus of federal regulators from responding to contamination, prevention, and to help with farm to table. Within the healthcare system at an institutional level, all the food service employees are taught about the hazard analysis and critical control points. We also refer to them as the HACCP. In HACCP, biological, chemical, and physical hazards from raw material production, procurement, and handling, as well as manufacturing, distribution, and consumption of the finished food product are all controlled. And these trainings are discussed with all the staff, from receiving, cooking, serving, and food handling. They're all taught about the high-risk foods and how to prevent illness. Nursing staff need to be cognizant as well, and we benefit from food safety education because we also sometimes help prepare the patient for meals, handle their trays, we open beverages for them, sometimes we unwrap food, and even feed them. And so it is important for us to know these high points of concern. It's really an important part of our nursing assessment to consider our patients' preferences for food and asking our patients if there are any cultural, ethnic, or religious beliefs related to their food, food preparation, as well as food preferences. What we consider norm may not be considered norm for them. Understanding the common food preferences and patterns that are used by different cultures of patients that we are taking care of will help us to identify better food choices for those individuals, and it will also help to lower the number of meal refusals. With the diversity of food choices that we have in grocery stores and restaurants, Americans have adopted really many foods into their daily lives, and perhaps there are less foreign foods than we've had in past generations. We're a little bit more open now to try foods across different ethnic groups. However, there are still many adults that prefer simple food choices, or what they might be considering comfort foods, over something that is unfamiliar to them. And at the same time, we can also enhance our foods with simple herbs and spices like garlic, onion, parsley, perhaps dill, to help our patients to take these very simple food choices and increase the intake of individuals that may have lost a sense of smell or taste as well. It's also important to note what types of herbs and spices your patient may not like. Consider also medications and treatments such as chemotherapy that may alter their taste buds. If the patient complains that the food doesn't taste very good, then we should take that opportunity to help them find and select something different, or maybe help them to add some of these herb and spice additions to their meals. More recently, traditional complementary and alternative medicine have become a part of life for many of us. And because of this, we need to address this increased interest of not only ourselves but our patients. The National Institute of Health created the National Center for Complementary and Alternative Medicine. And within this, we are thinking about traditional, complementary, and alternative aspects of treatment, approaches, methods, and these components are not associated with conventional medicine. When we use the term complementary medicine, we're referring to non-Western healing approaches that are used at the same time as conventional medicine. For instance, think of someone who takes a prescription medication to lower their hypertension. This is a conventional way. But also, they attend yoga classes for physical and psychological benefits. This is complementary. Naturopathic medicine is based on non-invasive natural healing that recovers a patient from disease and helps them to achieve wellness. The system incorporates techniques from both Eastern and Western traditions, and they might include techniques such as acupuncture, exercise, massage, and dietary alterations. Alternative medicines and therapies are used instead of conventional medicine, and an example of this would be to use herbal supplements that include shark cartilage to treat cancer instead of using chemotherapy or surgery. When working with patients that have a preference for complementary and alternative medicine, our nursing judgment has to be used. However, we need to accept our patients' preferences without judgment of alternative approaches, but allowing a mode of communication between the healthcare team and the patient to really understand what certain supplements and therapies are being used for specifically, and trying to come to a place of commonality and trying to pick the best therapy moving forward that incorporates their preferences. If you're unsure, we can refer to nutritionalists, especially the registered dietitian as well, and anyone who has special training in complementary and alternative medicine. Integrative medicine merges conventional medical therapies with the TCAM modalities. And integrative medical centers are available in larger areas, metropolitan areas, and even teaching hospitals. If you really enjoy and take interest in complementary and alternative medicine and treatments, you can now receive a Master's of Science degree in nursing in holistic care. And this is a specialty that provides integrative care techniques and approaches to nursing. And because it's becoming a little bit more accepted, insurance companies have gradually increased coverages for treatments that are maybe within the realm of complementary and alternative, because they recognize the cost benefits of these approaches. Patients that may seek complementary and alternative medicine are those that have pain, cancer, headaches, dietary intolerances. And we think about the biologically based therapies that will use materials that are found within nature, such as different nutrients, foods, and herbs, to treat, and also incorporating supplements. Maybe a patient will take an alternative dietary pattern. They use aromatherapy and other natural treatments. Now, functional foods contain physiological active substances or bioactive substances, and these foods have been modified to increase nutrient density. They've been fortified, enriched, or even enhanced. And some functional food components are marketed as dietary supplements. Think of beverages that are enriched with herbs. Think of there are some beverages that may contain St. John's wort, and this is a supplement that can be effective in treating depression. But there have been recently St. John wort added to beverages, but really the amount is really ineffective. It's kind of pointless. So when you're looking at functional food products, your patients also need to be aware that when they're selecting these products, what amount is necessary to have or to be able to experience the benefit of that. And unfortunately, this area of food is not really well regulated, and there are few controlled clinical trials that have been completed for such food supplements. Physicians, dietitians, nurses, the healthcare community at large strongly recommend that nutrients be consumed rather than just taking a supplement of that. So if there's something that you can eat and add to your diet, it's much better than just taking the supplement of that product. Specific supplement combinations have also been recommended as a safety net for infants, children, teens, pregnant women, elderly, so those that are most at risk. And we have more knowledge now of nutrients and pills, powders, liquids that improve dietary intake. We know pregnant women need folic acid and iron, and if they're not getting enough through their food intake, then a supplement is needed. Children and teenagers may not be getting enough iron or calcium, so a supplement may be provided. And our older patients may require additional vitamin D and calcium. These are all following the vitamin mineral supplement dietary reference intakes. Regulation and labeling is pretty big in helping to regulate supplements. And we consume them in tablet form, liquid form, capsules, extracts, powders, concentrates, gel caps, liquids. And it's really based on the definition. The dietary supplements are not drugs or food additives. How do we make this distinction? It affects the way they are regulated and facilitates the approval process. Now, drugs and food additives require more stringent testing for safety and efficacy. So this is why we call them supplements, because they can enter the marketplace more quickly with fewer data confirming the function and even the effectiveness. And so, with that being said, when your patient is ordering and consuming supplements, they may be spending money needlessly because it really hasn't had the scientific evidence. It may also delay medical treatment, and most of the time they have not been tested appropriately. And we want to include this in our nursing assessment. What types of products they're using, for how long, what they believe they're using it for, and perhaps, if they have a picture of the label or you could tell us what it is more specifically, then we will be more informed and able to make better adjustments to their medical treatment. Another area of discussion is regarding genetically modified foods, or GMO foods. And GMO foods are and have been DNA altered or modified through genetic engineering, mostly from the DNA of bacteria, plant, virus, or animals. And the purpose of these GMO foods is to increase food supply, make these foods more shelf stable, and to improve the quality. However, the drawback is that some people could have allergic reactions to these modified foods. According to your textbook, consuming foods containing ingredients derived from GMO crops isn't any riskier than consuming that same food from crop plants that have been modified by conventional plant improvement techniques. Corn, soybeans, summer squash, apples, potatoes, canola, these are examples of crops that have been improved by genetic modifications. This helps to alter the taste profile sometimes to increase economic value, conserve biodiversity, decrease carbon emissions, support human health, according to the IFIC. Now we're going to transition into patient feeding anytime oral feeding cannot be established. When the GI tract is used to provide nourishment, the feeding is a form of enteral feeding. This includes liquid diets, soft, solid food diets, and any type of nutritionally complete formulas that are administered orally or via a tube feeding. When a patient is not able to eat orally for more than a few days, then we need to transition to a non-oral method. If the medical staff talk about enteral nutrition, they're usually referring to tube feeding. We use tube feeding techniques when patients aren't able or maybe even unwilling to consume an adequate amount of nutrients and calories by mouth. And when this happens, as well as when the GI tract is functioning, nutrients can be provided via the feeding tube. So two things need to be established. The patient doesn't want to eat or cannot, they're unwilling, and the GI tract has to be functioning. Then we can use a feeding tube. And we place it into the alimentary tract. And when the GI tract is functional, accessible, and safe to use, then enteral feedings are preferred over a parenteral type nutrition. And this is because physiologically, there is more benefit in maintaining the integrity and the function of the gut. Enteral tube feedings are much less expensive than parenteral nutrition as well. Tube feedings can be part of routine care. And when a patient experiences inadequate or reduced oral intake over a previous week, we can start to think about tube feeding. Now, other conditions may warrant enteral feeding also. Dysphagia, major burn patients, someone that has short bowel syndrome after a resection, or maybe someone is experiencing intestinal fistulas. And fistulas are abnormal passages that can occur between one organ to the next. In this case, the intestines. Conditions under which tube feedings are helpful but may not be routine can be if someone is involved in some type of major trauma, or they're undergoing radiation, chemo, or a patient that might have chronic liver failure or severe renal dysfunction. However, tube feeding is not always the best option. It is of limited value if intensive chemo leads to GI tract dysfunction, or if adequate post-op oral intake is expected to resume within 5 to 7 days. And if enteral feeding is not contraindicated, then the registered dietitian would recommend starting enteral nutrition within 24 to 48 hours after the injury or admission to the ICU. So what would be contraindicated for enteral nutrition? If they are hemodynamically unstable, if there's a bowel obstruction, if there's high output of the fistula, or there's a severe ileus. The benefits of starting enteral nutrition early include incidence of less risk for malnutrition, fewer complications, faster wound healing, and even shorter length of hospital stays. There are types of formulas that we can use to feed our patients enterally. And for many years, these formulas were prepared with the use of vitamin, minerals, and food products and a blender. But today, we have a more extensive variety of commercially prepared formulas, and they are more nutritionally complete. And some are formulated specific for conditions and disease disorders. We have commercial products that are preferred over hospital or home blended solutions because we know that there is a known nutrient composition. We can refer back to that nutritional content, and there's controlled osmolality and consistency. There's also much concern about preparation and storage, and these commercial products are more easier for both. Standard formulas or polymeric formulas are composed of intact nutrients that require a functioning GI tract to be able to digest and absorb the nutrients. Standard formulas can be characterized into blenderized food products, milk-based products, high-calorie lactose-free products, and also normal-calorie lactose-free products. Fiber-containing products are low osmolality and are used for patients with abnormal bowel regulation. And these type of formulas will contain fiber from natural food sources or even soy polysaccharides. Elemental formulas are also called pre-digested or hydrolyzed formulas, and they're composed of partially or fully hydrolyzed nutrients that can be used for a patient with a partially functioning GI tract, someone that has an impairment of the ability to digest foods or absorb nutrients. If they have pancreatic insufficiency or bile salt deficiencies, then you would use these types of products. These products are also lactose-free, usually hyperosmolar, and they're not palatable. They're best suited only for tube feeding, and they're used less often because patients don't really prefer these, and most patients can tolerate standardized formulas instead of the special ones. We also have modular formulas that are not nutritionally complete by themselves because they are just a single macronutrient. So you have one that might have glucose polymers, protein, or lipids. They're added to foods or other enteral products to change the composition when nutritional needs can't be met otherwise. Well, specialty formulas are designed to meet specialized nutrient demands for specific disease states like diabetes, renal failure, liver failure, someone with pulmonary disease, or HIV. For critically ill patients, immune-enhancing formulas can also be considered. And these products, they contain omega-3 fatty acids, antioxidants, and other additives as well, and they require additional supplementation with vitamins, minerals, or trace elements. How do we select our formula? The numerous types and brands of enteral feeding products on the market can make this process somewhat complex, but really you're trying to see, can the patient digest and absorb nutrients? Then we're going to pick an elemental or polymorph formula. If individual nutrient requirements determine a specific type and amount of tube feeding formula, you'll use that as well. And the registered dietitian is assisting the physician or the healthcare provider when they are ordering, and it does require ongoing assessment and nutritional status examinations to determine whether the patient is able to tolerate the formula and if they're getting appropriate nutrient requirements. The different feeding routes of enteral nutrition, we have nasogastric, where the tube is passed through the nose to the stomach, or nasoduodenal, it's passed from the nose to the duodenum, small intestines, or nasojejunal, and this will pass through the nose to the jejunum. We also have an esophagostomy, which is surgically inserted into the neck and extends to the stomach. You have a gastrostomy tube, or what we refer to as a G-tube, is surgically inserted into the stomach. And we also can put a jejunostomy tube, which is inserted into the small intestines. Now, placing the feeding tube into the different areas through the nose is the simplest and most common feeding technique, and it is preferred for patients who are going to resume oral feedings within a few days. However, if you have a patient that is going to require more long-term treatment, then surgical implementation of a tube directly to the small intestines or the stomach is going to be the treatment. GI function needs to be determined, also to determine what feeding tube placement is best. If a surgical placement of a feeding tube is necessary, then the procedure will require surgery with general anesthesia, and the placement of a percutaneous endoscopic gastrotomy tube can be performed with minimal sedation, has fewer complications in surgical placement as well. So this is called a PEG tube, and PEG tubes will place the feeding tube into the stomach via the esophagus and then drawing it through the abdominal skin using a stab incision. The healthcare team also needs to determine the duration of the enteral feeding, and just like we have to make a choice of what tube is appropriate and what formula is appropriate, we need to select based on the route and the duration. And if a feeding tube will be used for short duration, then of course non-surgical placement, that's probably the better bet. But if the feeding tube will be placed long term, then we use surgical routes. And you can see here the administration of enteral feeding tubes. Methods are continuous, intermittent, or bolus type feedings, and you would use a continuous tube feeding for patients that have not eaten for significant periods of time, or patients that have impaired GI function or uncontrolled type 1 diabetes. The advantages of this is that the feeding is administered at a constant rate over a 24-hour period, and this will allow formulas to be delivered over shorter periods, and patients have more time to move, and it promotes oral intake when appropriate. But the disadvantages is that the feeding pump has to be accurate, and there's going to be a continuous drip by gravity if possible. But this is also less accurate than the tube. Intermittent feedings are indicated when we need to infuse feedings at specific intervals throughout the day. And when this happens, we take the total volume of food determined by the physician and the dietitian, or the total volume of nutrients, and we divide that over 4 to 6 times per day to see how much we are feeding at each intermittent interval. The advantage of this is it requires only simple equipment. It can be used in a home setting as well, and it may be more physiologic than continuous infusion. Many times these feedings can be administered by gravity over 30 to 90 minutes. The disadvantage is that if your patient doesn't have a pump, the feeding has to be monitored pretty diligently because you don't want to overconsume or underconsume, or take too long or not take long enough. Bolus feedings are only appropriate when you are feeding into the stomach, and it involves feeding large volumes of formula in a short amount of time, and usually we do this by a syringe. It's more manageable for a patient at a rate of 30 mLs per minute or a volume of 500 to 700 mLs per feeding. And of course, it has to do with physical tolerance as well. The disadvantage of a bolus type enteral feeding is that it's associated with increased risk of aspiration, regurgitation, and GI side effects. Tube feeding is not without its complications, and most of the time these problems can be prevented simply by good food prep techniques, hand hygiene, and also being cognizant by the nursing staff and anyone who's administrating the formulas or the foods to ensure proper technique is being used to start the feeding. Now, there could also be some GI problems like diarrhea, nausea, vomiting, cramping, distension, and even constipation. Mechanical complications can also exist. The tube may be displaced or obstructed. It may lead to pulmonary aspiration if it's in the wrong spot, and it can cause mucosal damage as well. In terms of metabolic difficulties, we may have situations of hyperosmolar dehydration or overhydration. We may be at risk for abnormal blood levels of sodium, potassium, phosphorus, magnesium, where they could be too high or too low. We can cause hyperglycemia, respiratory insufficiency, and even see rapid weight gain. You can see the different causes and treatments that are available for the complications that were discussed. Now moving on to parenteral nutrition, and fortunately there are alternatives when a patient refuses to eat or can't eat with a feeding tube, or if the tube is contraindicated. And parenteral nutrition involves providing energy and nutrients through an IV, intravenously. When the nutrients are infused into a large diameter vein, so you're trying to use like the superior vena cava or subclavian vein, this method that we can use is total parenteral nutrition, or TPN. We can also use central parenteral nutrition as well. When smaller peripheral veins are used, then we call this peripheral parenteral nutrition, or PPN. And usually this is through the forearm. So what are the components of parenteral nutrition solutions? They contain the same nutrients and components that we would use in an enteral source as well. We're still using water, amino acids, dextrose, electrolytes, vitamins, and trace elements. Fat can also be included as well, and usually the fat is going to be separate, and it can be administered through piggybacking the fluid. And it's added directly into the parenteral nutrition also. And when it's added directly, it's called a 3-in-1 solution. Now, carbohydrates are the most commonly used in parenteral nutrition in the form of dextrose monohydrate, and it's used as the primary energy source because of its hydrated form. Dextrose solutions are available in initial concentrations of D5 all the way up to D70, and higher glucose concentrations can also be used when patients' fluids need to be restricted. Lower concentrations are used to help control hyperglycemia. Amino acids or proteins can be provided in parenteral nutrition solutions in a mixture of both essential and non-essential crystalline amino acids, and they're available with or without added electrolytes. And it's important that we understand that the amino acids can be used for protein synthesis and not just as an energy source. Amino acid solutions are available in different concentrations and with various amino acid compositions. Fats through IV lipid emulsions are used as concentrated energy sources to prevent the development of essential fatty acid deficiencies. And there are commercial lipid emulsions and formulations that are used: soybean oil, safflower oil, or sometimes a combination of the two. Can be added with glycerol for added isotonicity. Egg phospholipids can be added and used as an emulsifying agent as well. There are some newer formulas that use olive oil and fish oil because they are providing a source of omega-3 fatty acids. Traditionally, lipids have been delivered peripherally with a piggyback, but like I said, you can also add it directly into the formula. When providing parenteral therapy, baseline serum triglyceride levels need to be confirmed before administering IV lipids so that we can monitor and administer accordingly. Electrolytes and minerals can also be provided by general amino acid solutions or as a combined electrolyte concentrate added separately as individual salts. And we have commercial electrolyte solutions that are available. We can provide magnesium, phosphate, potassium, just depending on what the requirements are for your patient. And again, labs will be ordered to get baseline information. Trace elements like zinc, copper, manganese, chromium, and selenium can also be used and are found in combined commercial solutions. Vitamins are dependent upon whether you're treating an adult or a pediatric patient. And these formulations can be used for IV administration, and they're commercially available as well. In a clear vitamin deficiency, we can get multiple doses of vitamins in accordance with their clinical status. And lastly, there are bioactive substances, additives like prebiotics and probiotics, antioxidants, and glutamine. And they can benefit certain patients, and they need to be administered based on individual assessments done by the healthcare team. When administering parenteral nutrition through a peripheral IV, the solution must be isotonic and limited in the kilocalories and the proteins. Only used for short-term nutrition support, and usually in concentrations of about D5. Just like enteral tube feedings, parenteral nutrition can also have some complications, and so monitoring needs should be established and protocols should be met. And this is going to vary depending on your institution and the patient population, but you can see this guide here for monitoring your patients on TPN along with the rationales. However, you'll go into this a little bit more deeply in your med-surg course. Technical complications are related to catheter placement, and pneumothorax can be prevented by careful insertion of the central line using proper techniques. Septic complications, just like technical complications, are not unique to parenteral nutrition. Infections can be local or systemic, and they usually occur because of poor technique and aseptic catheter care. And lastly, metabolic complications are common because of the requirements that are needed, electrolytes, energy. It differs from patient to patient. Hyperglycemia is common and can be treated by administering insulin or by adding it to the solution as well. We can also reduce the dextrose percentage or ensure that the total calorie load is not excessive for that patient. For select patients, home parenteral nutrition can be an option, and a specialized catheter can be used to reduce the possibility of infection. It's placed through a tunnel under the skin. It exits the chest at a place where it's easy for the patient or the caretaker to care for it and to use it. As with the other types of enteral and parenteral nutrition that can happen at home, it requires that both patient and caregiver are willing and they have the ability to perform the daily procedures involved in the administration of the parenteral nutrition, and also they will still need to be monitored in terms of labs, temp, weights, glucose measurements, and even fluid. Usually home health will be involved and they will provide equipment, supplies, services, and follow up. They're also available for troubleshooting. Now, patients may be scheduled to receive home parenteral nutrition at night during their sleep. We call this cyclic. And it's to allow the freedom to leave home and go to work and do the things that they would do in their normal day routine. Sometimes, if the GI tract is functional, your home parenteral nutrition is administered only on selected nights per week, and this is to supplement the oral intake that they already are provided. This is an expensive alternative, but it does cost less than hospitalization, and it allows the patient to be discharged sooner, and in many cases, it really helps them to resume a productive lifestyle. When we have one modality of feeding and we're moving to the next, there has to be a period of adjustment or weaning. And the transition to an adequate oral intake to maintain the nutritional status is going to really differ from each patient. And even though your GI tract responds quickly to enteral feeding, our patients that have been on TPN for a long time, they actually have decreased appetite, and it can take them up to even 2 weeks before they start to feel hungry again. And this is why we really need to ensure this transition from oral or tube feeding. It will help to progress to ensure continued adequate intake. If they're not hungry, they're not going to get enough nutrients. Although stopping TPN too quickly can also result in hypoglycemia, so they need to be monitored very closely. Long periods of parenteral nutrition without enteral feedings can also result in atrophy of the GI tract. And if it's not contraindicated, minimal enteral intakes like sips of fruit juices will help to maintain normal GI tract physiology and gut mucosal immunity. However, it has to be recommended and regulated by the healthcare provider. Now, before weaning from TPN, you have to really get a good assessment of the GI function, and this is going to prevent problems with delayed gastric emptying, nausea, vomiting, and diarrhea. As we start to taper the TPN and start to increase the oral or tube feeding, we need to document the actual ins and outs of fluids and enteral intake to facilitate nutrient sufficiency. We still need to get a good understanding of how much is being consumed. And if oral feedings or isotonic formulas aren't well tolerated, then we can also move into elemental formulas as needed. When we go to tube to oral feeding, we need to assess patients' ability to swallow. We need to stop tube feeding an hour before and after meals because we're trying to promote their appetite. And as oral intake increases, we start to decrease the volume of the tube feeding. We can discontinue tube feeding when oral intake now consistently exceeds 2/3 of their estimated energy requirements.